Today, I will be talking a little bit about perinatal mental health more broadly, and Dr. Shaw will follow up talking about some of our work in the NICU. So I'm really excited to be here today talking about perinatal mental health, particularly with this audience. I think I enjoy talking about mental health with non-mental health providers more than anything. And I think it's a really exciting time to be in perinatal healthcare in general. I know that the American Heart Association just put out a statement talking about the role that psychological health plays in cardiovascular health. And I think we see that more and more of this integration happening where psychological health is really being centered in healthcare broadly. And so I hope that if you are attending today, you can kind of reflect on what role you play with families during this period of time, whether you see families one time or very frequently, thinking about the ways in which you can kind of integrate psychological health into your care as well. So, to start off, I think it's always helpful to kind of take a step back and have a broad perspective of what we're looking at during this period of time. I think there's very few other periods of time in an adult's life that is as dynamic as the perinatal period. So, we know that if we're taking a sort of biological, social, and psychological perspective on what's happening during this period of time, that there's a lot of changes happening, and all of these factors impact one another and are impacted by one another. So, just looking at some of the biological or physical changes that are happening during this period of time, we know that there are a lot of significant hormone changes happening in the body, particularly for mothers. Endocrine functioning is changing, definitely changes in sleep quality and the ability to get sleep as frequently as you might like. Genetic predisposition can play a role, and then neurological changes, research has showed us, are happening during this period of time. Socially, certainly, whether this is your first baby or your fifth baby, there are a lot of role transitions. So, relationships are changing, and things that you used to be able to do or roles that you used to be able to play that might have been very meaningful to you are changing during this period of time. That includes routine changes, things that might have been familiar or things that you really leaned on as part of your everyday routine is going to have to change when a baby comes into the picture. Socially, I think that, we're getting a little bit better with the idea around what it means to be a parent and how much support parents need. But certainly, unfortunately, there are still social expectations and pressures placed on parents, what it means to be a good mom, what it means to be a good dad. And then psychologically, again, adding a baby, whether it's your first or not, is going to mean new stressors, whether that is thinking about childcare, financial stressors, and then certainly what we see a lot is barriers to coping. So many times parents are describing for us what used to work for me is no longer available. I think one of the biggest things that I think about with the population that I work with is exercise. Oftentimes people lean on exercise or movement, getting outdoors to kind of manage anxiety. And after you've had a C-section or just caring for a new baby, needing to come in and visit the NICU, maybe that's no longer accessible to you. So you're kind of grasping for new coping mechanisms. Certainly, if you have a psychiatric history, whether that's personal or a family psychiatric history, that can also place you at increased risk for experiencing a perinatal mental health condition. So I think what's really nice, and I know that you are more familiar with this than I am, is that overall in the healthcare landscape during the perinatal period, we've seen the ability to screen for more physical health conditions and be more preventative in the type of medical care that we provide for new moms. But unfortunately, I think we're still very behind in our ability to do this for psychiatric conditions. So this is obviously unfortunate because a lot of research has shown us that psychiatric conditions are some of the most frequent complications of pregnancy and childbirth, as well as the fact that substance use and suicide are among some of the leading causes of death postpartum. So I think, again, this is a place where we still have a lot of room to grow, but I do think that we've made a lot of progress in this area. I know that the AAP and ACOG have put out recommendations for screening, so we're really trying to get better at identifying some of these mental health difficulties. But when you think about it, typically these screening efforts don't include major factors that we know contribute to death in the postpartum period, like substance use, like domestic violence. And typically, these screening efforts tend to focus on only depression and only on mothers. So we certainly continue to have a long way to go. But what research does show us is that about 20% of women will experience a maternal mental health condition during this period of time. As you're probably familiar, postpartum depression is the most talked about and researched mental health condition during the perinatal period. And we know that this occurs, generally speaking, in about 1 in 7 women and about 1 in 10 men. But it is often the case that we feel like anxiety disorders kind of fly under the radar. In my experience, and also a lot of experts talk about anxiety disorders perhaps being even more common or more prevalent than depression. And certainly we see postpartum depression and postpartum anxiety and prenatal postpartum depression and anxiety co-occurring together. And despite the fact that we know how prevalent some of these conditions are, we still find that there is a significant lack in sufficient access to the services that these individuals need. So, if we were to talk technically, we know that the actual definition of the perinatal period includes the time from conception to a baby's first birthday. But when we're looking specifically at mental health, and this is probably true for other health conditions as well, we know that it doesn't just start at conception. One study showed us that about a third of women who end up having a mental health condition during the perinatal period will enter pregnancy already having some sort of anxiety or depression disorder. We know that another third will develop their symptoms during pregnancy, and a little bit more than that will develop their symptoms during the postpartum period. This is most commonly when we see that onset happen. And another study showed us that when untreated, these symptoms can last well beyond what we technically define to be the perinatal period. So a study showed that of the people who had depressive symptoms during the perinatal period, 25% had depressive symptoms at 3 years postpartum if left untreated. You'll also notice in the gold bubble here that the peak onset of postpartum depression tends to be around the 3 to 6 month period postpartum. And we know that there are a lot of changes happening around this period of time. So it could be that mothers are going back to work, that they're stopping breastfeeding, that menses is returning. We know that for the infant, there's often developmental progressions that can lead to sleep regression. And obviously, that can place a lot of stress on a parent. In addition to that, at about the 6 to 9 month period, this is where we actually see the peak incidence of suicide. And while this is still well within the postpartum period, we know that unfortunately, a lot of the adult focused sort of services that we have in place to surveil mental health symptoms have nearly all fallen off by this period of time. So a lot of times, a lot of our parents are falling through the gaps. So, as you can see from this figure alone, the what we refer to as perinatal mental health disorders is much more than what some people refer to as the postpartum. So, not only do perinatal mental health disorders also occur prenatally, but we know that it is also more than just depression. There is a wide landscape of some of the things that we typically see for parents during this period of time. And we won't have the opportunity today to go over all of these, and certainly not in depth, just with our short period of time. But I will be highlighting a few of the ones that we might see most commonly or some of the most significant ones. But as you can see in this picture, what we notice during this period of time often is attributed to mood and anxiety disorders. And while this is absolutely true, I think it can be important to recognize that there are additional things that can happen with parents that I think sometimes we forget to assess for. And for example, traumatic stress and trauma is a big piece of that. And I think the complexity that is demonstrated by this figure is that a lot of these presentations sort of overlap symptom-wise. So if we're talking about mood disorders, a parent who's having difficulty managing their mood or difficulty managing anxiety, that can show up in a lot of different disorders. So not only is it important that we really know what it is that a parent might be experiencing, but we also recognize that parents can experience multiple disorders during this period of time, such as perinatal depression as well as post-traumatic stress disorder. I also wanted to note, obviously, that even when it is the mother who's experiencing some sort of perinatal mental health condition, that obviously has implications for the entire family. So it's important that we are recognizing the impact that this can have on fathers or non birthing parents as well. And certainly, many of these disorders we do see in fathers and non birthing parents. I know that there has been more and more research that has demonstrated that one risk factor for paternal depression is maternal depression. So if all we're screening for is the mother's depression and we recognize that she has postpartum depression, we're probably expecting that her partner is going to be able to provide some sort of support. But a father who is very depressed themselves is likely to have a hard time supporting a depressed new mother as well. So, just briefly taking a look at some of the risk factors for perinatal mental health disorders, we know that some of the first few listed here are really common in all mental health disorders. So, having sort of a personal or family psychiatric history, a trauma history, financial stress. But some of the ones that come a little later are ones that we tend to see in our more critical care population, high risk pregnancy, the NICU, where families describe having had adverse obstetric outcomes in prior pregnancies, a history of infertility or pregnancy loss, traumatic birth experiences, experiencing a mother's intensive care, the baby's intensive care, or having a baby with special needs, a sudden discontinuation of psychiatric medication, especially without the support of another mental health provider, or challenges with feeding the baby. So, knowing that many of you who are here today at this conference, it's likely that you are familiar with some of the gross disparities in maternal mortality in the US, particularly for Black women. So, in addition to some of the anxiety and fears that can come up for a parent knowing those statistics, unfortunately, women of color, including Black women, Latina women, Indigenous women, also have higher rates of perinatal health disorders but lower rates of actual diagnosis and treatment. We know that some additional vulnerable groups include women with disabilities and women with their own personal military deployment or have a military spouse. So these groups are sort of more vulnerable or more likely to experience perinatal mental health disorders. And some of the barriers that we know exist in terms of them actually getting the treatment that they need include the lack of training in perinatal mental health. So, just within the mental health field, there aren't a lot of people who specialize in perinatal mental health. But I think even more broadly, looking at the healthcare system and providers in all specialties, really being culturally competent and prepared to provide the type of support that each of these vulnerable groups needs. We know that there are structural barriers like difficulties with insurance, transportation issues, childcare that prevent people from being able to connect to support. And we know that medical providers are saying that they really lack the capacity to integrate this into their work, as well as issues with reimbursement. We also know that research shows us that issues with racism and bias in medicine have created barriers to people receiving the care that they need, and that some families and patients have stigma, mistrust, and fear as additional barriers to care. So, again, going back to this piece around it is not just about maternal mental health. We know that when a mother is experiencing a perinatal mental health disorder, this has implications for the entire family, including the baby. So, if left untreated, we know that during pregnancy, this places the baby at increased risk for premature birth, low birth weight, being small for gestational age, low APGAR scores, and fetal demise. For mothers who have a perinatal mental health disorder that's left untreated, during pregnancy, they are more likely to have poor adherence with prenatal care. They might lean on self medication and using substances, poor bonding with the baby, and self harm or suicide. During the postpartum period, if left untreated, perinatal mental health disorders can lead to a baby having a NICU admission. As the baby gets older, behavior problems, developmental delays, insecure attachment, poor school outcomes. I actually also just saw a study that linked untreated postpartum depression to emotional eating in the child, even as early as 4 years old. For mothers, if left untreated, this can put them at increased risk for cardiovascular disease, poor adherence to medical care, challenges with breastfeeding, relationship issues, impaired responsivity, sensitivity, and bonding with the baby, child neglect and abuse, again, self medication, and even infanticide, homicide, or suicide. So, obviously, it's important that we are taking a preventative approach and making sure that we get families connected to the resources that they need because this can have long term effects for the entire family. So, starting off with the baby blues. So, this is the most common condition. And I say condition because we know that it is not an actual mental health disorder, but we can see this in up to 80% of new mothers, a very common experience. It's thought to be caused, or at least some contributing factors are hormone fluctuation, sleep deprivation. And we know that on the surface, it can look similar to depression. There can be crying spells, a mother might describe that she's having difficulty controlling her mood. One minute she's happy, one minute she's sad. A sense of emotional reactivity. So I know often moms will describe just feeling extra sensitive to things, and exhaustion as a new parent. So what can be helpful is really understanding how to distinguish between this and what might be an actual mental health disorder. So these three sort of factors listed on the side can help us to do that as providers. The first is the timing or onset. It's important to recognize that the baby blues happen very shortly after birth. So this is not something that we would start seeing a month after birth. It happens very quickly, typically. The severity intensity is also something that we want to look at. So the baby blues and the symptoms that we typically see around that are more mild in nature, and you really don't see a major impact in functioning. For duration, this typically lasts 2, at most 3 weeks following birth. And so again, if you're finding that a mother is describing that this feeling is not going away, or any of the other factors that you're recognizing, "Oh, that doesn't quite fit," it's likely that something else is happening. I also wanna note that, it's important to know that just because we're still in that 2 to 3-week postpartum window doesn't mean it's not something else. Sometimes we can just think like, "Oh, that's just the baby blues because you just had a baby," but it is possible for other disorders to happen sooner, or to kind of manifest sooner. So, speaking of which, perinatal depression, as we talked about, can happen prenatally or in the postpartum period. And we know that, again, this is the most researched and discussed mental health disorder during the perinatal period, occurring in about 1 in 7 women and 1 in 10 men. I think what's helpful to point out here is that it is not just a depressive episode that is occurring during the perinatal period. Yes, we might see some similar symptoms like difficulty with sleeping, difficulty with appetite, maybe some low mood, not really interested in the things that you used to like to do. But above and beyond, we really see impact in relationships and particularly the role of being a parent. So, some additional things that parents usually, especially moms, will talk about is a difficulty connecting with the baby, difficulty with attachment, what we refer to as mom rage. So, a real sense of rage or irritability that feels really hard to control, and sometimes a real overwhelm just with the everyday care activities for the baby. Some of these things can, maybe make us think that this might be depression. We also recognize, if you're familiar with the EPDS, the Edinburgh Postnatal Depression Scale, that there are a few items on there related to anxiety, and it's also very common to see some anxious worries or feelings within postpartum depression that may not necessarily meet criteria for an actual anxiety disorder. So, speaking of anxiety disorders, I'm going to highlight here perinatal obsessive compulsive disorder. So, perinatal OCD is definitely something that experts say is underdiagnosed. And we'll talk a little bit more about why that might be. But some recent research shows that this occurs in about 7.8% of women in pregnancy and about 16.9% of women in the postpartum period. So, there are sort of two distinct pieces of OCD that you want to kind of keep in mind. The first are the obsessions. So these are very unwanted and persistent and intrusive thoughts, images, or urges typically related to the safety and well-being of the baby or your role or in transition of being a parent during that period of time. So some examples might be fear that something is bad's going to happen to the baby. They might fall, the baby might grow sick, but certainly some that are talked about less frequently, but we know happen frequently, are concerns of harming the baby. So, parents might think like, well, what if I, am just so sleep deprived one day that I shake the baby, or having images of them doing something, dropping the baby while they go down the stairs. And this includes actually sexually harming the baby as well. Parents are so concerned that they're going to do something to harm the baby in some way. And you can recognize that this can bring a sense of shame, disgust, embarrassment. And oftentimes, I think this is why we believe that this is underdiagnosed, because it's hard to share that with a provider that you're having some of those worries or concerns. So oftentimes these concerns are so distressing that they lead to compulsions. So compulsions are behaviors or acts, or thoughts that a parent might engage in repetitively to kind of decrease that anxiety. So some examples here: mantras or prayers. Some things that we see a lot are checking behavior. So a mom or dad might describe that they're getting up several times in the middle of the night, even though there is no medical reason or any reason from like the pediatrician to be concerned about needing to check on the baby that frequently. And so you can recognize that this disorder can be really debilitating and can certainly impact a parent's level of functioning. And so if we ever recognize that they're engaging in behaviors like this that are really impacting just their everyday life, it's a sign that we certainly want to get them some support. For postpartum psychosis, this is one of the more rare disorders, but more serious ones. So this occurs in about 1 in 3 women per 1,000 live births. And this is one of those disorders where, especially initially, it can look similar to some mood and anxiety disorders, where you might see some shifts in mood. Someone might be describing that they're having some of those fluctuations in their mood. They might seem anxious or express worries, a little agitated. And again, those things can exist in other disorders as well. But what can be really distinctive about this disorder is that it typically has a very stark and rapid onset, and deterioration thereafter, where you're really noticing changes in the mother's overall functioning, disorganized behavior, disorganized thought, really not seeming very logical. And so this can be hard to track over time if you're not seeing a patient frequently enough, or you've only met them this one time and you're kind of uncertain. So some of the additional things that we want to look out for are paranoia, feeling like everyone is against them, delusions, hallucinations. Those will certainly be indicators that we want to get this parent support. If the parent allows you, you can also lean on collateral information. So talking with another provider that they're working with, or a family member, a partner, to get some more information about, do they really seem very different than their typical self, and above and beyond what we would see from a new mother. And lastly, to touch on perinatal traumatic stress and PTSD. So we know that about 33% of birthing people report feeling traumatized by their childbirth experience, and about 17% of birthing people will experience symptoms of post-traumatic stress. So some examples around the childbirth experience that can lead to some of these statistics are related to having an emergency C-section, failed pain medication, a perception that your medical providers weren't sensitive or weren't listening to you during that period of time. Some additional sort of traumatic experiences can be having severe preeclampsia, a fetal diagnosis, a NICU stay. All of these things can lead to traumatic stress or even meeting criteria for post-traumatic stress disorder. So as you can see here, these are some of the common symptoms that we tend to see in post-traumatic stress disorder, and those who just have some of these symptoms related to traumatic stress. So nightmares or flashbacks of a traumatic event, and this could be multiple events, throughout the course of the perinatal period. There could be a lot of really stressful events that are leading to that. Intrusive thoughts or memories of the traumatic event, hypervigilance, or kind of being on edge, kind of like they can't settle down. Sometimes you might see parents pacing a lot. They seem a little irritable or on edge. Certainly that will lead to difficulty with sleeping. Oftentimes parents report negative thoughts or feelings about their experience that can include feelings of guilt or self-blame related to what has happened, and difficulty feeling like you can experience the joy of becoming a new parent. So, how to think about your role, again, kind of closing the loop here around what role do you play and how can you contribute to this? You certainly don't have to become specialized in mental health, but I think it's important to recognize that, again, no matter how frequently or what your role is, if you're interfacing with moms or dads during this period of time, you have the ability to really empower them to get the support that they need. I can't tell you how many times someone has entered my office or I've met with someone who the reason why they got there is because an OB, an MFM, a nurse, someone mentioned something to them or sat down with them and had a conversation with them. So I really don't want you to underestimate how important it can be to just plant some seeds. And so the first thought here is, how do you invest in mental health more? So I think all of us, even us in mental health, can always think about ways to improve and integrate this more into the everyday work that we're doing. So I know that you're very busy and you have other things that you need to do as part of standard care. So maybe it's about thinking strategically about ways that you can integrate this into your standard care. When you step into a room and you meet with the family, how do you check in with them? When they share with you how they're feeling, how do you use that opportunity to validate their experience and to provide some education? That, it sounds like what you're describing is something that we hear a lot from families, and it doesn't have to feel this hard. Really empowering them to take the next step in getting the type of support that they need. I always like to tell people that you shouldn't be suffering. I think we can sometimes inadvertently talk people out of getting the support that they need after having a baby because we might say, "Oh, yeah, this is very common. You're sleep deprived, you have a new baby. Yeah, that makes sense." And we're trying to validate them, but that can sometimes come off as a little dismissive. So I think it's important to take a note of that, it's important that they recognize that while there might be an adjustment period, they should not be suffering. So helping them understand the difference between what's normal and what is common. It may be common, but if it's not normal, then you can help get them the support that they need. The second step here is being able to convey a sense of safety and support. So again, I come back to this because I think it can be so easy, especially for those of us who've been in the field for a number of years, to feel very comfortable in your style and your approach. But I think it's always worth kind of considering ways that you might improve the way that you convey this sense of safety and support. I think when you are able to lean on curiosity, asking questions, listening more, it's more likely that you are going to learn more ways to effectively help your patient and the families that you work with. That certainly allows you to be more culturally sensitive and responsive instead of having a sort of one size fits all approach. And I think this can be especially important for families from marginalized groups who maybe already come into your room with feelings of maybe I won't say how I feel today, or a fear of if I do share, what is going to happen? Are they going to take my baby away? Those are certainly fears that a lot of families have. And then finally, I think most obviously, it's important that you have a plan. I know that one thing that can get in the way of us actually checking in on a family's mental health is feeling like we don't have resources for them. And unfortunately, we still broadly need to improve in this area. But I think one thing that you can do if you are working in a clinic or an institution that does have mental health providers, whether that's a psychologist or a social worker, please try to get familiar with the services that are available and how they work. If right now you're thinking like, I don't quite know exactly how they work, I would definitely encourage you to maybe meet with that provider and learn a little bit more about that. Because again, I can't say enough how many times people have come to me, patients have come to me because a trusted healthcare provider told them, I really recommend that you go talk to the psychologist, or I would recommend that you at least do a one-time meeting and see if it could be helpful for you. Certainly making sure that you have an understanding of how to address safety issues at your particular clinic or the unit that you work in. And then I would certainly recommend following up. So if you noted that a family was struggling, following up with them in the next appointment, or if you put a referral in, certainly following up in the chart to see, did they get connected to services? Because unfortunately, sometimes people do fall through the cracks. I also wanted to provide some language because, again, I know that it can be the case that you are someone who really appreciates the importance of mental health, but sometimes it can feel a little awkward, or you feel like you don't exactly know how you might ask certain questions or respond to certain questions. So I definitely recommend, playing around with the type of language that might feel good for you. So some of the ones that I, typically use are, it's typical for this to be a stressful time. Do you have people you can talk to about how you're feeling? Many parents describe feeling blank after having a baby. Have you felt this way at all? And certainly, an important one can be, have you recently had any thoughts that have scared you or left you feeling unsettled? I really feel like, it is more likely that you will approach these situations instead of avoiding them if you feel like you have helpful language that you might use. And then finally, I wanted to point out some of these really helpful resources that are available to all of us. Certainly, there are a lot of different resources that we can pull from. So there's information and trainings offered throughout a lot of these organizations, as well as just like fact sheets, very brief kind of briefs related to mental health in certain groups or mental health in certain populations that can just help you kind of brush up on mental health in this area where you're not necessarily having to do a 6-hour training, but you can kind of use it just to stay on top of your the care that you provide. There's also a lot of patient facing information that you can utilize in a lot of these from a lot of these organizations. And then a really helpful piece that I find, especially with the Policy Center for Maternal Mental Health as well as Maternal Mental Health Leadership Alliance, they know that we need a lot of support with advocacy and policy in this area. So especially if you're a provider who feels like you could use funding, or you could use language to kind of advocate for services in your clinic or your institution, they have resources for that. People have thought about this already and created things like that. So I would certainly look into that. And then I wanted to spotlight Postpartum Support International for a few specific resources. So, the Perinatal Psychiatric Consult Program provides an opportunity for medical providers to call in and consult around medication management. I think this is especially helpful because we know that there is a shortage in medication providers, specifically who work with the perinatal population. So more and more, we are leaning on primary care providers to prescribe medication. And so if you are interested in kind of getting support in this area, if you feel comfortable doing that, this is a great opportunity for you to call and get some support around consultation and thinking about, what makes sense here for this particular patient. The helpline is certainly helpful to know about so that you can provide for patients, but I've also heard of providers calling this helpline to talk through learning about resources that could be particularly helpful for certain patients, especially if you don't have a lot of mental health support otherwise at the clinic that you work at. And then perinatal mental health training for medical providers is a specific page that they have at PSI where you can go and see all the lists of trainings that are specifically for non-mental health providers, which I think is really amazing. The MGH Postpartum Psychosis Project is a larger project that does a lot of research, but they offer free consultation for medical providers who feel that they could use some support if you're working with someone that you feel might have some budding psychosis, or if you are supporting someone that definitely has postpartum psychosis, you can lean on them for support as well. And then finally, as you can see with me spotlighting Postpartum Support International, I am a little biased. I volunteer for them and I have for a few years. And one of the things that I have found most profound is in my volunteer role, I don't lean on any of my expertise. I have very little time with the people who call in for local support in their area. I don't do a full assessment. I really just listen to their experience and make sure they get connected to the resources that they need. And I want to highlight that because I think, again, it's a reminder about how helpful just listening and showing someone that what they're experiencing, they are not alone in, and that it can get better. And so I just wanted to end with Postpartum Support International's sort of slogan that you are not alone, you are not to blame, and with help, you will be well. And if you forget everything else from this presentation, I hope that you can kind of convey that in the care that you provide to your families. Thank you.
Wow. Thank you, Dr. Poe. I'm going to take this opportunity to now welcome Dr. Shaw to the panel. Welcome, Dr. Shaw.
Oh, there we go. Hi, everybody. My name is Richard Shaw. I'm a psychiatrist at Packard Children's Hospital, and I work in the NICU with Dr. Poe. I've been working there for many years, and my talk is going to sort of piggyback onto her talk and to talk more specifically about interventions and how we think about the general topic of how to help parents who are going through these various perinatal mental health disorders. And I'm going to focus specifically on the NICU population. This is an area that Dr. Poe mentioned is a really high risk environment. Babies are born prematurely with often complex medical conditions and may go through several weeks of really complex, difficult treatment with a lot of scary medical experiences. And many parents come out of this experience with a lot of trauma. So I have a few disclosures, just a couple of books, but nothing that has any financial implications for this presentation. And I'm going to start out with talking about the whole topic of intervention in general. And as Dr. Poe mentioned, many NICUs and many programs in general do not have a lot of psychological resources, but there are lots of preventative interventions and steps and things that you can do in the NICU that can certainly prevent some parents going on to have psychological issues, both during the NICU and when they go home. So this pyramid is a way to sort of think about, I think, the universe of interventions in the NICU. And I'm going to focus just on the NICU today. The whole area of interventions in OB and perinatal and fetal centers and after discharge is a large topic. But if we look at this pyramid, you can see that at the very bottom, we have what we call developing a supportive unit culture. And this is really where a lot of groundwork can be laid to make the experience for parents a good one and to reduce some of the trauma that's going through. So NICU design is one of those areas. And fortunately, a lot of NICUs are now transitioning to single room NICUs or beds for parents. But obviously, some of the older open bay NICUs have a lot of issues for parents who often are exposed to trauma, not only from their own infants, but for watching things going on around them. And there's a lack of privacy and opportunity to talk about what's going on. So I think, fortunately, as NICU design improves and NICUs start to transition in their layout, that's going to be a very helpful thing. Trauma-informed care is something that you probably have heard a lot about, and there are different models of providing trauma-informed care, but essentially what we're talking about here is training the entire team to think about the impact of medical illness and hospitalization in general, but in this context, the impact of a NICU hospitalization on the family. And there are various programs that really incorporate, first of all, a lot of education to staff about thinking about trauma, recognizing what parents are going through, and maybe providing simple interventions or information. There are a lot of handouts. There's a program called the National Traumatic Child Network, Trauma Network, that has a lot of very simple interventions and handouts and materials that can be distributed to parents about how to help themselves and their babies while they're in the hospital and when they go home. Mental health screening is obviously a really large part of intervening because, as Dr. Poe mentioned, even though there's a high proportion of parents do develop psychological distress and mental health disorders in the perinatal period. A lot of them do not. And so when we're thinking about limited resources in terms of psychological interventions, we have to target in a smart way the parents who really do need that help. So screening, I think a lot of programs have anxiety about setting up screening programs. The one that we hear about most frequently is the worry that if you ask someone if they're suicidal and you don't have a team to respond to that, then there's a lot of risk, not only medico-legally, but just not ethically proper to ask parents about these types of symptoms if you can't intervene. But there are a number of screening measures. And although most of us think about screening for postpartum depression, I think it's also important to think about screening for postpartum anxiety and postpartum traumatic stress. And we set up a screening program. It was a pilot program in our NICU a few years ago. And interestingly, it was only about 10 to 20% of parents crossed a threshold where it was thought that further evaluation was necessary. And in fact, we had no suicidal parents. And that, I think, is certainly our experience in our NICU, is that parents do get depressed, but it's only a very, very small proportion, maybe 1 or 2 a year, of parents who actually do present with suicidal ideation. So I don't think that should scare us off from screening. But obviously, it does require an infrastructure and support from the hospital to finance the screening programs, because it costs money to integrate and implement screening, and then also to have a response. And then the other issue is just staff psychological support. And I think we are all very familiar now with the issues of burnout and traumatic stress, as hospitals increasingly demand more and more from the staff, and we are often dealing with more complicated and often higher risk families, and families with all sorts of different risk factors. And for many staff, there are very high rates of burnout. There have been some very large European studies of ICUs, particularly focusing on nurses, and 30–40% of staff will report burnout and PTSD. And we know that has a really large impact on how they provide care and how attentive they are to parents' psychological distress, and just how much bandwidth they have in order to provide support to parents. And there's quite a lot of research on the types of issues that are associated with burnout. And it's things, not surprisingly, like providing futile care, working with colleagues or supervisors who are unsympathetic, just high-risk patients in general. So that's our sort of lower level. And if we go up to the second part of that triangle, we come to preventative interventions. And a lot of these interventions can be done without a whole lot of cost necessarily. Psychoeducation is probably one of the most important parts of what we like to bring to our units and to our programs and our parents. So a lot of parents will go through the NICU experience and become really traumatized and go home and not understand why they have panic attacks, when they get calls from the hospital, why they have flashbacks in supermarkets when they hear the ping of the cash registers that are actually reminding them about the NICU monitors, why they are so hypervigilant and anxious around the care of their children, and often overprotective, and often seeking out medical care that may not necessarily be actually necessary. I'm talking here about the concept of the vulnerable child syndrome, which is a common finding in parents who have medically fragile children and infants, including children or NICU babies. And this is really an opportunity when people are in the NICU to help identify and refer people for treatment. I've been in many meetings where there have been presentations on PTSD in the NICU, and parents have come up and said, I've realized now I've been suffering from this for 10, 20 years, but I just didn't know what was going on. And I think that's one of the greatest ways we let people down, if we haven't informed them about what's going on. And so just simple education, for example, that, why, if you're having nightmares, how that might be connected to stress and trauma, how being either too afraid to leave the baby because you're worried something terrible is going to happen, or else, on the other hand, sometimes parents not wanting to come in and visit, or not wanting to be in rounds because they don't want to hear bad news. So helping people have a framework to understand these issues can be really, really helpful. Support groups or parent well-being groups. This is something we've been working on a lot in the NICU. And in theory, these groups should be helpful, because it would provide a peer network for parents to talk with other parents. But it's actually been surprisingly hard to get parents to attend our groups. But a lot of NICUs have had success in groups that are run by Child Life, that are built around art projects or sewing or creating handprints for their babies. So I think there are creative ways to get parents engaged, and just getting parents to start talking to each other and realizing that they're not alone in going through these experiences can also be very impactful. Parent mentoring programs, I think, have a really large role to play in our care, particularly in NICUs that don't have psychologists, and maybe they have a social worker, but the social worker is just overwhelmed dealing with basic needs like, transportation vouchers and more social service type of services. But there are many parent mentoring programs across the country. One of the ones that we've worked with is Hand to Hold, and they have the resources to help train NICU graduate parents in specific NICUs, so that they can provide some of the support services for parents. And parents often do like to talk to other parents who've been through a NICU experience, because they feel understood, and they feel that the parent mentors can relate to them. These programs also provide online resources like groups for dads, for moms. So if you are not working with a parent mentoring program, it's definitely worth reaching out to them, because these the people who run these programs have a wealth of experience and will often provide some of these services or resources for free. And then I put developmental care on this pyramid, again, as a preventative intervention. Obviously, in the NICU, the babies come out not looking the way they were expected, and parents don't always know how to go about handling them. They might feel nervous and insecure. We know that preemies often don't respond in the way that is expected, but you have to pick your timing when you're going to, handle them and interact with them, and learning how to let them rest and sleep when they're not ready for interactions. And if the interactions are mistimed, it can really create a feeling for parents that they are not competent as parents, and that can be set up in a chain of insecurity and difficulty bonding. So moving up to the third layer of the pyramid, this is where I think we would say that many of the more conventional psychology interventions are contained. So we're very fortunate at Packard. We have Dr. Poe, we have a team of mental health people. So we receive referrals from social workers. We do psychological evaluations. We then provide individual therapy for parents. We provide couples therapy because often parents do want to be seen together. And as Dr. Per mentioned, there's a high prevalence of stress and mental health issues in the non-birth parents. And then what we refer to as parent-infant psychotherapy, a probably even more rare resource, but it's very common for parents when they leave the NICU to have issues around bonding, maybe not to feel attached, not to feel confident, maybe to overreact to infant cues and behaviors. And so working with a psychologist or psychiatrist who's skilled in parent-infant work can be really helpful to help parents bond well and set them up for success as their children get older. And then at the very top, we have, these are the high-risk parents who are suicidal or have postpartum psychosis, and most hospitals will have resources for referral to a psychiatry consult service. Sometimes we have to take parents down to the emergency room if there's concerns about suicidality. But that system of care does need to incorporate something for those very high-risk parents at the top of the pyramid, and obviously support in referring people to women's wellness clinics and other services. Okay, so again, just talking about the whole universe of interventions, this is a pretty busy slide, obviously. I'm just going to focus on just the big picture here. So we do have on the top interventions. So this is where I would incorporate or list things like, what the NICU, how it's designed, and is there a nice parent room? Are there places for parents to sit and have privacy? And then the developmental care and the multi-stimulation programs that can be really helpful in improving development and shortening lengths of stays. And there's a number of programs that focus on auditory, visual, tactile, and vestibular stimulation. Then if we look at the interventions on the left, that left-hand circle, this is where we have things like individual therapy or groups, wellness groups, expressive writing that I'll focus on a little bit. And then on the right-hand side, there's the parent-infant work, where we work on improving parental sensitivity and parent-infant attachment. And you can see that these three circles all overlap, and often it's necessary to be doing something from every circle to really have a positive impact on the family. Okay, so now I'm going to move on a little bit to just some of the interventions that have been provided to parents in the NICU. And these interventions have targeted PTSD, depression, anxiety. And actually, it's sadly a pretty small literature. You can see that in this large literature review that was done, fairly recently, that there are only 15 articles. And some of the conclusions from this literature review that interventions that were found to be effective included those that emphasized education, psychoeducation. There's been a music therapy intervention, journal writing, mindfulness-based stress reduction, which I think has really a lot to offer, and then cognitive behavior therapy. And I think one of the interventions that I'm going to tell you about falls into that category. So I'm going to discuss briefly what we call a trauma-focused cognitive behavior therapy intervention for mothers of premature infants. And I apologize for those of you who've heard me talk about this topic before. But this was a study that we published in Pediatrics in 2013. It's one of the probably only, sadly, again, one or two randomized controlled trials to help reduce traumatic stress in parents. And in this study, we we had 100 parents, and we had 60 of them in an intervention. And the intervention, here you can see, contained two components. And one of them was what we call trauma-focused CBT. And how we developed our treatment manual was that we went to the Veterans Administration, where they do a lot of work on military and combat trauma, and they have a very nice evidence-based CBT intervention for PTSD in veterans. And we adapted a lot of components from that intervention, writing and content that was specifically relevant to parents and the issues that come up in the hospital. So that was a big part of that. I'll tell you a bit more about that in a second. And then the other was what we call infant redefinition. And this broadly embraces the concept of helping parents not view their infants as being super fragile and at risk, even though we know that some infants do have more medical risk factors. A lot of preemies grow up to be perfectly healthy and normal, but parents can still view them as being fragile and can parent them in a way that is not always best for their development. So the infant redefinition was to decrease the perceptions of infant vulnerability and really to enhance parents' feeling about their own confidence as being parents. So the cognitive behavior therapy, I mentioned earlier, psychoeducation is a big part of this. This is in letting people know what trauma and PTSD is, what it looks like in parents, how it might explain some of their behaviors. The cognitive restructuring is a very common psychological technique that's used in psychology and psychiatry, where we help people reframe some of their cognitions so that they are able to see the world or the glass more half full than half empty. And a lot of parents, come to the NICU with what we call erroneous cognitions. And these are mental schema or beliefs that actually are not necessarily evidence-based. So there's often a lot of guilt about how they feel they may have contributed to their child's premature birth or medical issues. A lot of hopelessness that things will never get better, that life will never be good again. And with our cognitive behavior techniques, we can help them change some of those cognitions so that they then have more positive cognitions, and then that can help them feel better and more optimistic. The third component is sort of self-distraction or thought stopping. That's another technique to help break the cycle when parents are getting in these very obsessional thoughts about how everything is bad. And then relaxation training, where we will teach things like breathing or progressive muscle relaxation, hypnosis. We have a really great medical hypnosis website that's available. If people, I can tell you about that at the end. These are just things that we can provide to parents. And what we're doing with all of these techniques is really giving parents a toolbox of how to decrease their reactivity and their stress when they get triggered by things that bring up these catastrophic thoughts. The last part of our intervention was what we call a trauma narrative, which is a very common technique used in trauma treatment, where we will have parents write down with prompts from us in a session the story about their birth, their premature birth, their experiences in the NICU. And we help them write it down in as much detail, paying attention to sensations and sounds and smells and all the traumatic things that went on during their time in the NICU. And often in the NICU, there's multiple stressful events that happen. And then in the next session after that, we transcribe their narrative, and then they read it back to us. And there's been a lot of data that showed that doing this with a therapist, going through the narrative, stopping at various points to talk about specific things that happened, processing that experience, addressing negative cognitions, helping them do breathing or relaxation techniques if they're getting anxious, that can really help decrease their trauma. The infant redefinition, I think I've covered a lot of that, but it's really encouraging people to be sensitive to their infant's cues. And one of the things we use here is a baby diary where, the typical baby diary is where the parent just writes down things about their infant, when they first smiled or walked or talked or took solid food. Our baby diary also includes observations that the parents make about themselves and how they were feeling and things that they were able to do with their baby. And so we're hoping, and at the end of the intervention, and the intervention was 6 sessions provided, 2 sessions a week for 3 weeks in a row. And they're writing their baby diary probably twice a week. At the end of the treatment, we have them compare their baby diary entries currently with what they were like when they first started the intervention, and just commenting on the big changes that have taken place, not only in themselves, but in their baby and their interactions. And this really, I think,
Dr. Shaw, I don't want to interrupt because you're doing great. And I just wanted to let you know you have 9 minutes left.
Thanks so much.
You're welcome.
Appreciate it, Patricia. Yeah, I think I'm on track. Okay. Yeah, so that's the infant redefinition. And we also focus a little bit on the overprotective parenting, kind of laying the seeds about what might happen when they go home and how they might be a little bit anxious and overreactive, and just helping guide them. And we actually have been working on some interventions with a colleague about sessions that occur after the NICU to help reduce overprotective parenting. Okay, so there was a control group that just received basically psychoeducation and assertiveness training. And this is a handout showing some of the typical misconceptions people have about their NICU experience, feelings of guilt, anger, sadness, as I described, and just showing people this one handout really helps them normalize, oh, I didn't realize that this is a common thing, and maybe I'm not so crazy that I'm having all these weird thoughts. So this is how psychoeducation can be useful. So I probably skip through some of these because these are just really some of the psychological techniques that we use for the cognitive restructuring. But there are things like examining the evidence, or what would I tell a friend. A lot of parents can really relate to what they would tell a friend if they were in their situation, and also learning that they could maybe apply that to themselves. And then positive self-statements. These are a list of things that parents can say to themselves at various times when they're feeling stressed. Things like, this is hard right now, that I can handle it. This challenge will help me grow. I can picture my baby big and strong. Relaxation skills I covered. And the trauma narrative, as I think I went into some detail about that. So one of the things that we can sometimes do if we don't if you don't have a psychologist at all in the NICU, there's evidence showing that if parents just journal 30 minutes a day for 4 days in a row, just writing free form, and there's a list of questions there, this in itself can reduce symptoms of PTSD. So this can be, anyone could just give someone a prompt on this and ask them to do this exercise, and it probably will have some benefits for the parents. Okay. So I just want to show you some results from the study. First of all, it was very popular, and parents, all of them in our study of 60 parents, had a lot of satisfaction. 4.63 out of 5 found it very helpful. 4.25 out of 5. A lot of them said they wished could have been given to the non-birthing parents. And this shows some of our findings. We've got 3 boxes here. We've got a trauma scale. That's the Davidson trauma scale on the left. A depression scale in the middle. That's the Beck Depression Inventory. And an anxiety scale, the Beck Anxiety Inventory. And you can see that the blue line, well, first of all, there's baseline, and then there's 4 to 5 weeks after the intervention was completed, and then it's 6 months. And the blue dotted line were the control parents, and the red line were the ones that received our 6 sessions. And you can see that for both trauma, or for all trauma, depression, and anxiety, there were huge differences, and a very, I think, successful study. So group therapy, I won't spend too much on this, but we do think that groups have a potential to be helpful, and we adapted our individual therapy intervention, and we had, I think, about 6 or 7 groups of parents. The study started during COVID, so unfortunately we had some issues with recruiting people, and we had to transition to Zoom groups halfway through our study. But we did find that we published this article as well in Early Human Development. But here we were comparing the group therapy with individual therapy. And I think the main take-home message for this, again, we've got trauma on the left, depression in the middle, anxiety on the right. And you can see that the group therapy was effective. That's the blue line. Symptoms went down, and these were all greater than the controls in our first study. But the individual therapy seemed to be more effective. And then I think one other thing we did in this study is that we compared Zoom therapy with in-person therapy, and actually we found slight benefits for in-person, but not hugely so. Okay, so I have like a few minutes left. Is that right, Patricia? I just wanted to show you our website. I just want to stop my share. How do I do that? And pull up one other handout. So we have a website. It's on the last slide. And the treatment manual that we used is available. It's called ProMoms for Preemies. So you can see here the 6 sessions that we used. And each session starts with goals. There are handouts that go along with each session. And the blue text are instructions to the therapist. The black are literally, we just read this to the parents. We conducted this therapy with graduate students who were not licensed. They were wonderful students from Palo Alto University who've played a huge role in developing our program. And we trained them in one weekend. And then they were able to, with supervision, provide this treatment. And so if anyone is interested in learning more about this therapy, or you have someone in your NICU who, a social worker or a psychologist who wants to learn more about it, please feel free to put them in touch with us, with Dr. Poe or myself, and we can share our resources. We have some training materials, yeah, we really want to help try to disseminate and spread some of these interventions that we know are helpful. I think that's the end of my presentation. Thank you so much.
Thank you, Dr. Shaw. I'm going to have Dr. Poe come on with you, and we have many questions in the Q&A. So there is one that I wanted to share with you, and the question is, for people who have PTSD from their birthing experience, what do you recommend for their subsequent pregnancy?
Celeste, do you want to take that?
You're muted.
Yeah. Sure. So I think that this question probably could be interpreted a lot of different ways, because there's a lot of pieces for a subsequent pregnancy that you want to think about. Certainly for individuals who've had a previous traumatic experience, going into an additional pregnancy can be difficult at a lot of different stages. And I think it can be helpful to remember that about trauma, that there are a lot of reminders about a previous experience. So I think preventative care is the most important. And that is true of all providers that are touching that particular family. So from the point of conception, throughout the pregnancy, the birth experience, I would certainly recommend preventative care around planning for mental health support. So thinking about during pregnancy what you might need, that would help you kind of cope with the different symptoms that come up. Thinking about coming up with a birth plan while recognizing that adaptability is important because unexpected things can happen during a birth experience, and certainly postpartum having a plan for mental health support, again, because we know having had a previous traumatic birth experience will increase your likelihood that you will have some traumatic stress symptoms with a subsequent pregnancy.
Awesome. Thank you. Dr. Shaw, there is a question for you. It says, thank you, Dr. Shaw, for mentioning the newer model of single private rooms for the infant and their family. I've never thought about hospital-acquired trauma in terms of the setting in the NICU. Can you speak to this?
Yeah, thanks for the question. So parents get traumatized by all sorts of things in the NICU, particularly the open bays, because they're not only things going on with their own babies, but sometimes, as we know, codes are called and suddenly there's screens on wheels are brought in, and the parents might be sitting with their baby right next to them, and they hear, it's very frightening when a code is called, all the people that show up. Sometimes because of HIPAA reasons, you might be next door to a baby and maybe have got to start connecting and talking to the parent, and then suddenly they are gone the next day. You come in and they're not there, and you don't know, what does that mean? They got better and went home, or did they die? So there's a lot of uncertainty. And so I think, but it's interesting that I do think the private rooms are really great, but there actually has been some research, I believe, showing that being in a noisy NICU is really good for infant language development, and being in a really quiet private room is not as good. So we have to be thinking about, all of the impact of our interventions. But yeah, the hospital is a source of great trauma. And it's not just the experiences of watching what's going on with your own baby or someone else's baby, but it's the staff interactions. Unfortunately, many staff who've worked for decades in a hospital forget what it's like, what it would be like to be a brand new parent, who's maybe 19 years of age, and they have a preemie, and I think an experienced staff member might just not understand and be able to step into the shoes, and they might be not willingly, but maybe just not attentive to how their behaviors are affecting the parents. And another example is that parents don't understand what the monitors mean. So it might be one occasion where a monitor goes off and they call a code, and then the next day the monitor goes off a second time, and the nurse just looks up and goes back to their charting. And then the parent is thinking, well, what's going on? Did they not notice? So I think we always have to be thinking about explaining and educating what's going on to reduce trauma and to decrease anxiety.
Thank you. So there is another question. It says, and I think it's for either of you. It says, how do others address the disability paperwork? The mother is on pregnancy disability for 1 to 2 months, but their OB rarely wants to continue this paperwork when they are not treating the postpartum depression.
I can answer that. I think that this is I actually just talking to another NICU psychologist about this. This is definitely one of those areas as I was mentioning that there's just a gap in provider care. What we tend to see, and I certainly see this in longer NICU stays for families, is that there tend to be no relationship with a primary care provider. So many women describe that they either don't have a primary care provider or don't have a strong relationship with them. And so once it drops off from the OB, I'm their only other provider that is providing support. And this is something that I feel pretty passionate about. And so I have done the research to kind of feel comfortable providing that support to extend disability. So I tend to do that with the families who need that. But I would definitely recommend that we try to start this much earlier. In the same way that when babies discharge from the hospital, they need to have a pediatrician appointment. I hope that we can get to the point one day when we do that, the same thing, but for a primary care provider for birthing parents. I think that is critically important. But also talking with moms about what their plan is for going back to work and what the process might be if they need to extend, because sometimes I think parents are taken by surprise that their OB is not willing. And I understand why if you're no longer working with the patient, but I think that we need to be thinking about this a lot sooner and providing them some support.
So there's another question. It says, how can we provide a safe communication with medical care providers for BIPOC families without the risk of CPS automatically being contacted instead of addressing the condition situations before it gets worse?
That's a great question. I think in the NICU and specifically, I can really understand where our nurses and our neonatologists and our nurse practitioner colleagues are concerned, because these are very sick babies and they're going to be sending them home. And so there's often a concern about the baby's well-being and making sure that someone is going to be able to care for that baby. So I can understand where a lot of the worry and questions come from, but I definitely think that listening more and learning a little bit more from our patients, this is sort of where that comes in. I think that there are times when a medical provider might hear one thing and that it immediately brings up alarms. For example, a family that might be unhoused, or a family that might have some sort of family dynamic going on that would make us concerned. But I think we always want to learn a little bit more about the family's context and what their actual resources are. And certainly that approach of, instead of connecting them to CPS, thinking about ways that we can get them resources that they need early on. So again, that's where the interdisciplinary collaboration comes in. And at our NICU, I think we do an excellent job with really leaning on our social workers and thinking about ways that the social workers can kind of get those resources to families early, instead of having those sort of knee-jerk reactions of needing to call CPS. And that allows the families to feel like you're partnering with them instead of sort of policing them. And because we know that, these are very real concerns for BIPOC parents.
So this question, I think, is addressed to the both of you. It says, as clinicians, what is top on your wish list to address perinatal mental health when you are getting ready to discharge the baby home? What are you wishing for needs as a clinician?
Question. Do you want to go first?
You go ahead. Yeah, I think because you're really working in this area, Celeste.
I mean, I feel like the most obvious answer is capacity, which I'm sure all of us wish for, but I think that the reason for that is because we see how painful it is for the drop off in services that occurs when a baby goes home. And we know a lot about how families feel and how parents feel after the baby discharges. A lot of the reason why we have the gaps in care that we have is because we can only do so much. I think, since I've been here, I've really tried to support that more continuity of care and in starting early and kind of extending post discharge. But without the actual capacity to do so, we really do our families a disservice. So probably it would be like more funding and more support from leadership, more priority around this area, to provide that sort of holding of the whole family even after they go home.
I think we have room for one more, and it says, it's in terms of risk. Are those with diagnosis such as ADHD at increased risk of PP depression?
Me to that one, Dr.
Yeah,
Shaw?
actually, that's a great question. I mean, I think ADHD puts you at risk for many things. So I would imagine yes, probably in multiple ways. You know, like not being able to follow up on resources or medications that they're prescribed. But yeah, Celeste, do you have other things to say about that?
Yeah, research does show us that neurodivergence in general does place you at increased risk for perinatal mental health disorders. I think that some of the things that can come up specifically for ADHD is the parenting expectations and things that it takes to care for a baby, to care for yourself, can already be challenging when you have difficulties with staying organized, attention span, things like that. And we know that individuals who are neurodivergent are also at increased risk for mood disorders in general. So having increased anxiety or depression. So certainly during this period of time, as we pointed out, when all of these stressors and things are happening, it can really complicate it. And the other thing that I think is important too is that neurodivergent people navigate the healthcare system differently and they have different needs. And sometimes I think this makes it hard for them to get the care that they need, which of course increases their vulnerability during this period of time.
Okay, so I think we have a couple of more questions that we can address because we still have time. So if you don't mind, it says, what tool do you think is most reliable and sensitive to screen for perinatal depression and or anxiety, or is it too soon to screen when baby is still in the NICU?
Well, we've used the PHQ-9. That can be used for both moms and dads. The Edinburgh postnatal depression scale is very, very widely used. I don't think it's ever too early to screen. You know, we recommend screening antepartum in the fetal center. I think it's good to screen in the NICU to help figure out who needs services. It's good to screen before discharge to know who might be more at risk and need referrals and help. And then I think it's important to screen at 4 to 6 months because a lot of things happen during those first 6 months. And some parents, as Dr. Poe mentioned, you know, I think there's a bump up in symptoms around 3 to 6 months. So if we only screen once, we're going to miss a lot of important, you know, opportunities to intervene. And I personally think it's important to not just screen for depression. I think we have to screen for PTSD and anxiety as well.
And there is one more question. Have you seen any connection with community or doula care outside of clinical care that has impacted patient outcomes in a positive or negative way?
I don't know that I have necessarily seen it impact patient outcomes in a negative way. And I'm not an expert on doula care, but some of the positive patient outcomes that I know exist around decreasing traumatic birth experiences. So feeling like you have someone who is supporting you in the process of childbirth with advocating and who could kind of help in that environment certainly will decrease a parent's experience of a traumatic birth if possible. And then in addition to that, just the follow-up care that can happen in the postpartum period, having someone come by, check in. Again, this is a unique resource that we have because our systems are not set up to do that, especially when doulas are able to go in the home and provide that kind of hands-on support for new parents.
Okay, one more question. Does the baby blues also include the father? And how do we best address fathers when dealing with postpartum depression?
A great question. So I think that the current understanding around what causes the baby blues are things that are more internal to the birthing parent specifically, but that doesn't mean that fathers and non-birthing parents don't go through their own adjustment period after having a new baby. I think because there's also a social and psychological component to it as well. So I think that any new parent needs to have some sort of eye on them and observation around this big transition. And then I always think that a big question comes around how to support fathers and supporting a mother with postpartum depression, which is really necessary because we see this a lot in the NICU where maybe the mother or the birthing parent is the one that has the more obvious distress externally. So a lot of dads are coming in and asking, like, I don't know what to do and how do I support her? Like, I'm in a different place. I'm trying to think more positively and I'm not as worried as she is. How do I support her in that? So we are providing a lot of psychoeducation and couples therapy, like Dr. Shaw said, about how to support that. But the other piece that I feel like goes under the radar is that I think that a lot of times dads or fathers are suffering and are also struggling, and it's harder for us to assess for that because there are a lot of pressures for them to be the strong one. They might have fears that if they were to break down, what would that mean for the birthing parent or the mom? And so I think that it's twofold. It's supporting the father and how to support the mom, but also providing some education and a safe space for him to share if he's also struggling.
Thank you. Thank you so much.